Good afternoon, folks. It's 2 o'clock here on the East Coast, and welcome to Billing 101 for Behavioral Healthcare. My name is Chris Williams. I'm the Marketing Director here at the ECHO Group, and we're glad that you decided to join us for the first of this 4-part series that we've put together, really focusing on and emphasizing the fundamentals and best practices that are specific to billing in behavioral healthcare. We're going to cover a variety of topics over the next 4 weeks, but our idea was, coming into this, was to make it manageable. So as we cover fundamental and basic ideas, we're going to do it in 30-minute increments so as to be more effective for your time and help us to be able to really focus on chunks of what can be a pretty large and daunting topic. So first, I'd like to tell you a little bit about the ECHO Group. The ECHO Group has been privately owned since 1981. We provide electronic health records, software, and a variety of services to behavioral health organizations across the country. Currently, we have partners in over 35 states. We also offer revenue cycle optimization services to our partners as well. We've been providing that service since 2001, and we're pretty good at it. Virtually all of our partners have realized improved billing performance since we've started working with them. So we're pretty proud of that track record. And given that experience and expertise, we wanted to share that with you folks as we move into the murky world of billing in behavioral healthcare. I'd like to introduce you now to Suki Norris. She is our Senior Knowledge Engineer. She's been with the ECHO Group for over 20 years now, and she's going to walk us through this first section, the first part of our 4-part series. So, Suki, take it away.
Thanks very much, Chris, and good afternoon or good morning, depending on your location. What we're going to cover today is a little bit of a discussion of our billing is in flux right now. I'm sure that's something that, as you all face billing on a monthly basis, you realize. Also going to define what revenue cycle is, how we define it, how it's defined in the industry. A little bit of a who's who are the major players as we look at revenue cycle, and standard billing terms, some of which you're going to use today, some of which may come up in other areas as throughout the 4-part series. And then finally, we're going to start with making our way through the revenue cycle, part 1. And if you look at the image to your right, we're going to cover the first 3 boxes: credentialing, verifying eligibility, and prior authorizations. So what do I mean when I say, or what do we mean when we say billing is in flux? Well, there are a lot of reasons. Many of you have followed the meaningful use process. That meaningful use changed not just workflow, but sort of put new pressures on various elements of that work process and fee-for-service. And that was the first inkling of some change. We then went through that lovely move from ICD-9 to ICD-10 and DSM-4 to DSM-5. And while most of the federal programs, Medicaid and Medicare, moved on the appropriate day, some of those private payers were a little bit slower. And so you had situations where you were billing with both prior codes and current codes. Medicare has come up with a new process known as MACRA, which really highlights the concept of pay for performance, focus on outcomes, and focus on really the reporting of these items as a determinant of what you're going to get of your reimbursement rate. And then finally, sort of encompassing many of those items, this concept of risk-based contracts. We've all heard how the world is moving from a fee-for-service to a more risk-based contract where the risk is going to be all on your backs or perhaps shared with the payers. What is revenue cycle? Well, revenue cycle is really that process from the from the service through the payment, through the reimbursement. In short, it's really how do you manage that information in each of your clients' accounts to ensure that the service that gets entered is going to be reimbursed by the appropriate payers. And that's really the goal on a monthly basis of your that is encompassed in revenue cycle. So who are some of the players that you have to that you deal with on a regular basis? Well, the provider, and that's your staff who are going to be providing services. The client, maybe consumer, are the folks who are getting those services. Those two are probably the most important players in this process. But to be reimbursed for those services, you're going to have to reach out to a payer, and that's the entity that is reimbursing for services. And finally, you may have heard of a clearinghouse. Some of you may use clearinghouses, some of you may have heard of those. But a clearinghouse is really something that stands between you and your payer. They get your claims, and then they will clean them, go through all the edits that they can go through in the hopes, and then they will submit it to the payer, and they will get the payments back and in turn send them on to you for processing. Standard billing terms. And remember, I did say that many of these aren't going to come up today, but they're still good to know. So accounts receivable. Those are the charges for your client services. Those are the charges that you submit on a claim for repayment. Days in AR. This is an important one. This is how long between the time that you claim for those services and you get paid for those services. The longer that time frame, the harder it is for the ongoing maintenance and the cost of managing the cost of your agency. Claim submission, well, that's really that putting those claims, giving those claims, and sending those claims to the payer. What's a clean claim? A clean claim is a claim that has gone through an edit cycle to ensure that it gets paid fully the first time the payer sees it. A remittance advice form, or an 835. That is an electronic claim, the electronic payment. That's how, once you claim, your payer is going to let you guys know that there's been a payment made. And really the question there is, are you able to bill your payers with 837s electronically? And if you do, will you get back an 835? Because the advantage there is the ease of, generally the ease of submitting that claim. You're not trying to deal with a bunch of pieces of paper. And also the ease of processing that payment. When you get an 835 back electronically, you should be able to automatically get those payments posted. It speeds up the time frame as you move through your payers, and it gives you perhaps a more accurate look at your reimbursement. And then finally, timely filing limit. What's the time period for a valid claim? Now, timely filing is really very interesting, I know, in a lot of Medicaid, because you're going to be different depending on the services. Mental health usually has a longer claim timely filing limit, whereas substance abuse is going to have a very short time frame. Oftentimes it can be as short as 30 or 60 days, whereas mental health could be as long as 6 months. The challenge here is to understand by your payer what that time frame is, because that's something your system is going to have to be able to track as you go along. Now we're going to look at the first 3 boxes of that image. Credentialing is the first box. And when I say credentialing, many of you think of sort of that traditional concept of credentialing. I am going to ensure that my providers have the licensure that they say they have. That license is kept up to date. They're doing their CEUs or their continuing education, and all that's in my system so that I know that when a psychologist is providing a service, they are in fact licensed to be a psychologist. Now there's another term that credentialing also refers to something else, something that is really very important to ensure full payment, and that is, are my providers credentialed with my payers? If you go back to MACRA as an example, MACRA is really looking at the credentialing of the providers as Medicare providers, including the appropriate numbering system or the number that Medicare gives their providers. But Medicare is not alone. Medicaid will do that as well as private insurers. So one of the most important pieces of credentialing oftentimes could be overlooked, and that is the credentialing with the payers. Why is this important? Well, first of all, with that more traditional type of credentialing, if your provider does not have an active license when the service is provided, you're not going to get paid for that service. And that's going to be something that comes up every so often, because providers may not really know what they're doing or how when their licensing needs to be renewed. Same thing with CEUs. One of the things you can do is keep an eye on CEUs to ensure that your providers are getting those continuing education credits which are necessary for their license to stay in effect. Payers, as well as regulatory agencies like CMS, have very unique sets of requirements and intervals for renewing credentials. As an example, if you use Medicare and they go from one third-party service to another third-party service, which has happened in many states, your providers are going to have to go back through a credentialing process with the new Medicare payer to ensure that you can keep billing Medicare and you'll keep getting reimbursed. But the same thing happens with providers. They're going to expect that you maintain that certification, just as your provider's credentialing has to be maintained, to ensure again that you're always able to bill for the services that those providers are providing. And typically, you can't retroactively prove credentialing. So if your provider was not credentialed as of the date of service, you can't go back retroactively and say, but wait, they got their credentials and it's up to date now, because the payer is going to say, well, but when the service was provided for whatever reason, there was a lapse of credential, that service is not covered. What are best practices? Well, the first best practice, and I'm sure many of you have tried this and really are working towards this, is to plan way ahead, especially when you get a new clinician. The idea being, every new clinician requires the same steps to be gone through. It's a repeatable process. You could have policies and procedures in place to ensure that for every clinician, when they start, you ensure that their license is in place, they have the insurance coverage they need, and that they also are going to be credentialed with all the payers that you would expect them to provide services. By putting this into a policy and procedure, as your staff changes, your ability to stay current with credentialing does not change. And what does this give you? Well, most practically what this gives you is a reduction to zero of credential-related denials. You as an agency know what services can be provided by what licensure. You know what services will be paid by what payer. So what this will do is ensure that when you put it all together, your provider has the credentials that you would expect, providing the services that you know, and will be paid by the payer that you are submitting the claim to. Again, Make it a repeatable process, and you will lower those denial rates to close to zero, as long as you understand the rules of each payer. Next up is verifying eligibility. Oftentimes, this is done with a 270 and 271. I suspect some of you are saying, what on earth is she talking about when she says eligibility and then says 270? Well, let me tell you, the 270 is a HIPAA transaction that many payers know, certainly your states know and Medicare knows, is an eligibility transaction. It is a request that goes out to the payer that says, hey, I've got this client. Can you tell me if that client has eligibility? This can be done on an individual basis. It can be done on a batch process. What it gives you back is an absolute instance of eligibility so that you know that any service provided during that eligibility period is going to be paid for. We're going to be reimbursed if all the other ducks align, as they say. If you can't do a 270, 271, and maybe you can and maybe you can't, most every payer also has an internet site or some other mechanism or a phone number you can call that you can get that same information. The real importance here is that by getting that information, you ensure that you will not get a denial based on lack of eligibility, because you'll get some indicator that you can put into your record that shows that you've obtained the eligibility that you were supposed to obtain, and that therefore you know that service is going to be billable. As I said, it's important because if you don't have eligibility, then you cannot be certain that you're going to get reimbursed for the service. Just because I show you my insurance card or my Medicaid card, does that mean I have eligibility? Well, maybe my eligibility lapsed. How would I find that out? Because I could submit a 270, 271, or I could log into the internet site where I can check eligibility, or finally, I could make a phone call and get that information up to the minute, accurate as of today, accurate as of the day of service. It can also oftentimes tell you what is the type of coverage it's had, what are the services that are covered, and other information that's critical to determine how you bill for services, what services get billed for, and how you're going to get paid. So the best practices here are really find out eligibility, confirm eligibility before a service is provided. Get that information electronically if you can, because then it'll be in your system, it'll be accurate, and you'll have all the indicators of it. If you can't, then go out to the electronic portals that payers provide, or on the internet-based portals, or finally, make a phone call, because most payers, and I imagine you know those phone numbers, will tell you eligibility as of a date certain based on a client. But if you really want to ensure that you're not going to lose payments because of absence of eligibility, you need to stay on top of eligibility status, and that will give you the ability to know and have a certainty that you're going to get reimbursed for services. The final piece is authorizations. An authorization is really getting an approval to provide a service in advance, generally, of that patient receiving the service. Sometimes you may be allowed to do 3 or 4 services before getting an authorization, and that authorization will encompass those services together with future services. An authorization is generally going to determine medical necessity as well as appropriateness of service. So you're going to do an assessment or some kind of process by which you determine what are the needs, the medical necessity of the client to receive services, and what are the services best designed to address the identified medical necessity. Why is this important? This might be the most important thing that we've talked about today. I imagine that many of you work with managed care companies or perhaps have other insurance companies that do require authorizations. In this day and age, most every state has managed care for some services. Maybe you do CHIP services, in which case you're required to get managed care. But there is managed care that you work with. But it's not just managed care that require prior authorization. Health homes might require them. Affordable care might require them. Many entities might require prior authorizations. You have to understand as you work with your payers whether or not authorizations are required and for which services authorizations are required. And you have to get those authorizations in place before you do those services. Authorizations can be very complex. Maybe you know this from the authorizations that you get. I've seen authorizations that are going to be based on visits, pretty common, hours, units of dollars, maybe specific time periods, or for the most complex, a combination of one or all of those. It's not just important that you get this prior authorization, but you have to then track those services in your system against the authorizations to ensure that you never step outside the authorizations. Because if you do, as I indicated, this is the most important item, you for sure will not get paid. Because if your payer requires authorizations and you don't have authorizations, you will not get reimbursed for that service. So what is your best practice? Your electronic health record or your paper record should have a completeness and accuracy of information. You've got to know all there is clinically about your client. Then you got to know what forms your managed care companies require. It's conceivable you have 3 managed care companies in your state, each of them requiring different forms. Not many states will force the managed care companies to have the same form. You have to know how to get the request and how you submit the request for authorization to the insurance company or the payer and how they will get you their response back. Do you call them? Do you fax them? Do you enter it into a portal? Any of those ways may be appropriate, but you've got to know which of those ways so it's done quickly and with as little time as possible, so that you can start to provide the services in a very timely fashion. You also have to be prepared to follow up with the payer to document the communications, to know what you've asked for, to see what, because part of this is they're going to look for clinical documentation, and you have to have that clinical documentation. They're also going to look for clinical documentation to support an extended authorization. All of this information has to be in your health record, be it electronic or paper. And then finally, you have to be prepared to to file an appeal. And we will be talking about that, as you see in the image on the right, in part 3 of our Billing 101. So I think there's a little time now that I can answer some questions.
Yes. Thank you, Suki. We would like to open it up for questions. You can go ahead and enter them. There's you should see a box, a text box on your screen, just to enter your question there. But to anticipate questions coming down the pike, we will make the PowerPoint presentation and a copy of the recording of the webinar available to you folks. They should be available on Monday, and we'll send a note out to let you know when you can access this information. Suki, we do have a question here, going back to a little bit earlier in the session, and the question is, where would somebody find a 270 form?
You're not going to find a 270. What you're going to find is that your payer puts out something called a companion guide. And what the companion guide is it just gives you some information as to what they would expect in receiving a 270. And then your electronic system, your electronic health record, should be able to create that form. It's a HIPAA form, just as they create an 837. Then it would get submitted, a 271 would come back, and that companion guide is going to tell you how to read that 271. But for all HIPAA transactions, the way you really go about getting them to work with each payer is by finding it's called a companion guide. It's what they would, and you can just look for it or ask them for it. And if they accept the 270, they'll have a companion guide to tell you what they're specifically expecting in that electronic form.
Okay. Another question we have is, what is the difference between prior authorization and pre-certification?
Pre-certification is generally this concept of you can do, essentially the insurance company tells you you get 3 visits automatically before you ever request an authorization. They have essentially pre-certified you to do those visits. And a lot of insurance companies do that, a lot of state Medicaid programs do it to get the client into treatment, and then to continue that treatment you would then submit. Those visits would be for an assessment or some kind of initial intake process. Once that's completed, you would then get that to the insurance company, who would then give you a prior authorization or an authorization for the subsequent visits that you would have.
Okay, and then I think you may have answered this, but there may be more clarification here. Can ECHO create a 270? Yes,
our system does create a 270 as well as read a 271. Again, we do that. We have the basic form, and then the basic electronic format. We may make minor tweaks based on a companion guide for any given payer.
Okay, another question. This person says that they've been told that their record NextGen does not generate a 270 within their system. Is that correct? I don't know that we can answer that. I'm sorry. I know that the ECHO billing system does, but with regard to other service providers that way, we can't necessarily speak to that. Any other questions at all? Well, all right. Thank you very much for joining us for part 1 of our 4-part series, Billing 101 for Behavioral Healthcare. Again, as I mentioned, this session and each subsequent session will be recorded and available to you on the Monday following our webinar. I will also post the slides and make them available to you as well. If you have any additional questions or comments or feedback on how we might be able to make these even better as we move forward over the next 3 weeks, we'd love to hear from you. So until next Thursday, April 13th at 2 p.m. Eastern Standard Time, have a great week, and we'll talk to you then. Thank you.
Thank you very much.